treats. That whole family has CDH.
Okay guys, we're going to get started with our last presentation for the day. Dr. Jason Gien is back this afternoon. We are going to be discussing long-term care of the CDH babies and treatment and how he follows them in the clinic and some of those long-term effects of CDH. So I'll go ahead and turn it over to Dr. Gien now.
Okay, so try to get this working.
Hold it down and he'll see the green light come on. Is it plugged in? The projector's not working. The switch is off, I think.
Oh, there you go. Sorry, that's this thing. The power strip is on. It should come on.
There it goes. That'll take a few minutes.
Thanks again for inviting me to be here, and sorry you have to put up with me again. That's kind of what your life becomes when you decide to have your baby managed at our hospital. You just end up having to put up with me for a long, long time. So anyway, the reason I became interested in the outpatient follow-up of these babies really stems from, so back in, I guess it was 2003 or 2004, and I gave a talk to our group on the outcomes of babies with CDH. And if you really read the medical literature about the outcomes of babies with CDH, the literature is pretty grim, with babies with CDH facing many, many challenges and hurdles as they get older. And they never ever describe outcomes like you when you read the literature. What's really out there in the medical literature is a population of handicapped children in a wheelchair-bound G-tube oxygen ventilators, and that's what you read out there in the medical literature when people talk about CDH. There's multiple papers that are published out there that will talk about things like Dr. Crumble-Home just spoke about. Yes, we've been able to improve outcomes. Yes, this is the best time for babies with CDH to be born. But while outcomes in terms of survival have improved, the papers will speak so much about how severely disabled CDH survivors are as they grow up and become older. There's definitely a huge, huge cost to this disease, and there's a huge cost to being a survivor with this disease. But what I really wanted to find out for myself is, are these outcomes really as poor as people say? Do these babies really do as badly as people say out there? So I gave this talk where I brought to light these issues, basically, asking our group, should we continue to aggressively support CDH babies, knowing how severely abnormal their neurodevelopmental outcomes could be. And a lot of people got very, very upset by the talk. I wasn't proposing that we don't continue to take care of CDH babies, but just wanted to try and generate some discussion. And then a lot of the kind of gray-haired older people in the room stood up and said, we absolutely have to support them because they don't do as badly as what the literature says. There's plenty very healthy CDH survivors out there. And so I decided to embark on this journey of outpatient follow-up of these babies, mainly for my own curiosity to see for myself, how do these babies really do as they get older, to see firsthand how they develop, and learn for myself what the challenges and hurdles are for these babies as they get older. And so all of us neonatologists are pediatricians as well, which allows us to provide primary care for any child. But what I really wanted to embark on was to provide primary care for survivors of CDH. So as I started my little practice, I had to obviously take care of lots of other kids who didn't have CDH. Things have evolved nicely in the last few years. really been able to narrow things down to really just care for CDH babies for the most part. So 90% of my practice is just survivors of CDH, with the oldest being around 5 years old or so, spectrum all the way up from babies who were just born and recently discharged. And so, what has been done at Children's up until now is that we have a clinic down in the outpatient building called the Special Care Clinic. And this is not a clinic designed for follow-up of CDH kids. But I didn't want to go open up an office kind of next to the hospital and say, that's my office over there, come see me. And so I needed a home, and this is a good place to build a home. We'll talk in the last few slides about kind of where CDH follow-up is going to be moving forward, and the Special Care Clinic is not a place where that's going to happen. But what this is a clinic which follows patients with complex medical conditions. And these are multiple different medical conditions, from Down syndrome to different genetic disorders, survivors of congenital heart disease, babies who have intestinal problems and can't tolerate any feeds at all, so are dependent on TPN at home. But what the clinic was really designed for was to follow ex-graduates from the NICU. And these are premature babies, the babies born between 23 and 34 weeks, who then survive their NICU course but need a place to be followed. Pediatricians out in the community, which we heard a lot about this morning, struggle a lot to take care of children with complex medical needs. They did pediatrics so that they could take care of healthy kids, give shots, deal with colds and ear infections, and not have to deal with the complex medical problems. Geriatricians, take care of the elderly in our community. Those are the ones who train to take care of patients who have multiple medical problems, who are on multiple different medications, and it wasn't pediatricians who ever wanted to take care of this kind of patient. And so patients with these kinds of problems struggle to find a home in the community and a place that can really take care of them, and take care of them with comfort. So what ends up happening is that a patient goes to a community pediatrician. Anytime they have trouble breathing, they're referred to a pulmonologist. Anytime they throw up, they're referred to a GI doctor. They listen to their heart, think maybe it doesn't sound right, so they end up going to a cardiologist. What you find is by the time the child's a year old, they're seeing 6 or 7 different subspecialists for the different problems they have. And that's why it becomes so essential that places that take care of CDH babies have a program in place that can really follow these kids. Because the problem you run into is when the child goes to see a GI specialist, the GI specialist himself is in the situation that Dr. Krummelholm just described. So if you have an institution, even that takes care of 20 or 25 CDHs a year, but there are 10 or 12 different GI specialists over there. Of those 25 CDHs, maybe 2 or 3 a year will need to see a GI specialist. And you have a GI specialist now who has seen maybe 1 CDH every 3 or 4 years, is now going to try help your child with whatever problems the child is having, which means a lot of unnecessary tests, a lot of unnecessary interventions, and a lot of workup that might not be completely necessary if they understood what a CDH child faces as they grow older. And so we saw this just the other day with one of our CDH survivors who had severe growth failure, which everybody in this room knows is a very common problem with CDH babies, even CDH babies who have gastrostomy tubes. So the patient went to the GI clinic, was seen by a GI specialist, had 11 mLs of blood drawn for workup for failure to thrive. Had an endoscopy done where they put a camera down into the stomach to see if there was inflammation and gastritis related to the reflux, and then ended up having a biopsy of the stomach as well. So had multiple invasive tests done that may not have been necessary if the patient really could have been followed up by specialists who deal with CDH all the time. And so that's really where we're moving towards and why we try to move away from this model of special care clinic, because while they take care of a lot of kids with very complex medical problems, the CDH is not something that they're familiar with down there either. And so we'll talk about in the last few slides, kind of the future of CDH follow-up at Children's here in Colorado. But what we do and what my role is really is to ensure growth. And when we talk about growth, we talk about both physical growth as well as developmental growth. When children leave the hospital, developmentally they undergo a huge change. That's why we like to get kids out of the hospital as soon as we can, even though sometimes to families it seems like we're rushing them out of there. But no normal, well baby spends the first 3 or 4 months of their lives laying in bed on their back in a hospital bed or even in a crib at home. And that environment is not developmentally good for any child, even a child who then goes through periods where their oxygen levels might be low, their blood pressure might be low, they've been on ECMO and had other procedures and interventions done. So even if we took a healthy child and put them on their back in a crib for 3 months and said, how are you going to do developmentally, they're not going to do very well. And that's why it's essential to get the child out of the hospital to a home environment where they can continue to grow and develop. And development is the thing that really takes off the fastest once the children get home. What we do as well is coordinate outpatient consultations and act as a central kind of information gathering base so that we can consolidate the information we get from the consultants. So if I decide I'm going to send somebody to see the GI specialist, my role in the clinic is to take that information that the specialist has and say, hold on, these 11 mLs of blood are not necessary for those tests to be done because this is a CDH baby. Growth failure is very, very common in CDH babies. Why don't we try for 3 months to give more calories and see how the growth goes? So that's my role, is to take information from consultants, not allow them to perform interventions that may be unnecessary, and then use the information they give to help guide the management. I need to be the quarterback of the team and prevent unnecessary plays or actions from happening that really might not be necessary for care of the baby. Lots of laboratory studies will occur, sometimes with or without my knowledge, and it really shouldn't in reality happen without my knowledge, but sometimes when kids go to specialists, laboratory work ends up being done without discussion with the primary care physician or the leader of the team. And so there'll be laboratory studies often that need to be followed up on. Vaccinations are an important part of what we do down in the clinic. When we talk about vaccinations, we talk about the standard ones that babies will get, even healthy babies, but then additional ones such as Synagis or the prophylaxis against RSV. We provide a lot of familial support. Going home is a very, very stressful experience for all families. I know you had to talk about that this morning, and part of my role in the clinic is to provide support to families and help with the transition from the inpatient to the outpatient setting. And so, what I really thought was an essential part of following up CDH patients is to have the respective knowledge of what went on inside of the hospital with the baby. And so having been there at the bedside when the baby struggled in the first 12 hours and ended up needing ECMO, and having been there when they had bleeding problems while they were on ECMO, having been there when complications occurred from a surgery or a procedure, it's essential to really understand, first of all, what the family goes through as they get transitioned to home, but also what the needs of the child are after discharge. It's hard to know what a child really needs if you haven't been there for the whole story. It's like picking up a book, starting at chapter 20 and saying, I really understand fully what's going on with this book and story. And so I feel like it's essential to continue to follow these babies, have been there all the time through the initial course, but then to see it through to its end, So usually we'll arrange follow-up really shortly after discharge, and that's really just a visit where we want to talk about how's life been at home. It's usually 24, 48, 72 hours after going home, just to really find out, what was life like at home? Have you been able to measure the right amounts of medications? How the oxygen works? Is all the equipment that you have at home actually working the way it's supposed to work? I like to provide family support with definite email contact, because that's the easiest way to get in contact with people, but often even by phone for the most critical patients. Patients where I feel very anxious with them being at home. I feel like a way to get hold of the doctor emergently without having to go through an office is key in terms of preventing disasters from happening at home at night. Unfortunately, there are babies who go home after everything they've been through and die in the middle of the night at home. And it's a fear that all of us have whenever we take a baby home. But it is something that does happen, and so a way for the family to get hold of me so we can talk about things without them having to wait 4 or 5 or 6 hours for a call back, or without having to rush to the emergency room when it's -20 outside and snowing, is definitely essential in terms of following a child with such complex needs. And then we need to sometimes follow patients very closely in the outpatient setting. So that could be sometimes more than once a week, or sometimes even just once a month is fine. But initially after discharge, patients are often needed to be seen almost weekly. So what we deal with after discharge are chronic respiratory issues, which happen to be a big problem that CDH babies are going to deal with after going home. Some of them don't have major respiratory issues after going home, but for the most severe babies, this is one of the big challenges they face. Development is something else, which is a huge, huge challenge after discharge. When we talk about development, we talk about gross and fine motor development, so not just whether we crawl or walk, but how do we use our hands and our fingers. And then cognitive development as well. How well does the child understand? How well are they able to integrate information as they get older? Feeding is a challenge for, I'd say, almost every family, even children who go home without G-tubes. Trying to get the child to eat and grow and get enough calories in is a big, big challenge. For the babies who go home with G-tubes, this is often a much, much bigger challenge. And it's something that we work through together. Growth, like we said, is a major, major issues for CDH babies after follow-up. Hearing, another big, big thing that needs close monitoring after follow-up. Vision is not so much affected in these babies. For the ones that are born premature, they can sometimes be something that requires close follow-up as well. And then ensuring that patients are getting the services they need at home in terms of occupational therapy, physical therapy, and speech therapy is important as well. And those are the major things that we follow up and have to deal with after a child goes home. So when we talk about the chronic respiratory issues, some of our patients will go home with what's called a tracheostomy, where they have a little hole in their neck through which a breathing tube goes in, and that allows them to be hooked up to a ventilator. So these are patients who, even with attempts at weaning them from a respirator, have lungs that are so small and underdeveloped that they just can't breathe on their own until they've been able to grow much, much more. And so these are patients who go home with a ventilator. The ICU moves from the NICU to their home, and they get managed with the ventilator in their home. The ventilator gives them time so that as they grow bigger, their lungs will grow bigger and they're able to wean from the ventilator. So now we're talking about a child who, growing from 6 or 7 pounds to 8 or 9 pounds isn't enough growth for their lungs to really allow them to breathe freely on their own. So these are kids who need to be more in the order of 20 to 25 pounds before they can really breathe on their own and they've had enough lung growth to do that. So this isn't a big population of kids, but I'd say probably between 5 and 10% of babies with CDH will need to go home with a tracheostomy and attached to the ventilator. One of the most common reasons why babies will get tracheostomies with CDH is because of anomalies with the airway, and so along with the heart being squished and the lung being squished, unfortunately the airway gets squished as well when all those organs are pushed up into the chest. So when the airway gets squished during development, the cartilage inside of it doesn't form normally and the airway becomes very floppy. So most of the kids who can survive the initial course of CDH actually have enough lung tissue there that they could really breathe on their own, but sometimes need to be attached to a ventilator just to provide that extra pressure to keep their floppy airway open. And that's the most common reason why a child with CDH would go home with a ventilator and a tracheostomy. One of the other reasons are babies who need nitric oxide long-term and who have pulmonary hypertension that's just too severe to manage with just nitric oxide through a nasal cannula would get a tracheostomy so that you could safely deliver the nitric oxide as well. With time they wean off the nitric oxide, but then you can't just take the tracheostomy out and they need to wean off the ventilator slowly over time. So the two most common reasons, like we said, are the floppy airway and the pulmonary hypertension, and those reasons would be the ones why a child might go home with CDH with a tracheostomy. We also need to screen kids at home for apnea, so any pauses in breathing, and this would be especially important in kids who go home with a ventilator. But there are also kids who have periods at night when they sleep where they stop breathing. They don't stop breathing for minutes, they stop breathing for seconds, but stopping to breathe for 20 or 30 seconds can cause their oxygen level to drop. The most common time that would be seen is in a child who had big tonsils or big adenoids. And so part of the follow-up for CDH babies is often aggressive removal of the adenoids and the tonsils. So it's really not recommended to remove those before a child is 3 or 4 years of age, just because as the child gets bigger, those tissues don't really grow with the child. So the child gets bigger, the tissues stay the same size, and it becomes less of an issue. But with babies with CDH, having those periods of apnea at night when they sleep from obstructing their airway from the big tonsils can cause their oxygen levels to drop and then cause pulmonary hypertension, which may have been gone before, to reappear. So anytime you're going to stop or take oxygen away with the child with CDH, it's really essential to confirm that they're not having periods at night where their oxygen levels are dropping, because that could really cause pulmonary hypertension to come back, and to come back quite aggressively. We know that the lung, even though the children do better, after a couple months or years of being home, the lung still isn't completely normal, and that lung is still prone to any insult that can cause pulmonary hypertension to come back. And so making sure at night before you take that oxygen away that they're not dropping their oxygen levels is key. Weaning medications and what to do with those medications that babies go home on is something else that we have to deal with a lot. A lot of CDH babies will go home with diuretics, so Lasix or Aldactone or Diuro, and those medications need to go away at the right time. Unfortunately for CDH babies, upper respiratory infections with different viruses can be a huge problem. Trying to keep them out of the hospital every time they get a cold can be a big challenge. So for you and I, a cold means a box of tissues and a night or two of restless sleep and maybe some achy bones and stuff. For them, it often can be life-threatening, and to try and keep these kids out of the hospital with just a simple cold can be a big challenge. And then lifelong screening for pulmonary hypertension and management of pulmonary hypertension in the babies who go home on therapy, and that therapy does include oxygen as well. So it's really recommended that these babies get an echo at least every year, sometimes even more often than that, after they're completely healthy. So not a kid who's 5 or 6 years old and who's at school and everything's going well. It's important to continue to screen for pulmonary hypertension, just because the main reason for it is that we don't know as the child grows how the lungs are growing, and there is always potential that the child can grow faster than the lungs are growing, making it difficult for the lungs and those blood vessels inside of the lungs to support the baby's or the child's circulation at that point in time. As we grow bigger, the heart has to pump more blood to the body. If those blood vessels in the lung aren't growing at the same time as the body is growing, the pulmonary hypertension can come back again, because now we're pumping a bigger volume of blood through the same small vascular bed inside of the lung. So it's essential that we continue to screen for pulmonary hypertension and make sure that it doesn't come back again after it's gone. In terms of development, when we talk about gross motor development, this is really sitting, crawling, and then walking. Fine motor is the use of hands, and whether the child, will go on to use tools. So recognizing, at you're of age that a crayon or a pen is not a chew toy, and it's something that you need to write with. Things that we need to screen for and watch. Feeding and talking is what goes into speech and development of that system. And I'd say the biggest challenges we've seen are far different from what's really written about and described in the medical literature. So oral feeding, obviously, for all kids, but the kids with gastrostomy tubes, is one of the biggest challenges we face, but something I feel much, much better about, having done this for a little bit longer now. So like I said yesterday, what we've seen most commonly is once the children get older, meaning 2 to 3 years of age, and they can really understand why food is being put in front of them and what they need to do with that, they very often initiate feeding on their own. And I think a great example is this child that I follow who had a left-sided CDH, got a Gore-Tex patch. I had a transpyloric feeding tube for a while, and then the tube got pulled out in the middle of the night. They could never get the tube to go back transpyloric, and even with just 10 mLs of food, the little baby would throw up almost all of it. So he actually ended up getting a Nissen in the G tube when he was just 3 weeks old, which is very, very early in the course. He had quite severe reflux. He re-herniated when he was about probably 8 or 9 months of age, and got that repaired and dealt with. But really had absolutely no interest in oral feeding at all. I probably had the worst oral aversion that I've seen in any child that I've followed in the clinic. So severe that he wouldn't put toys or hands or anything even in his mouth. It wasn't like most of the kids we see where they'll put toys and hands and different things in their mouth, but as soon as you give them food, they have no interest in eating. But then, this child came from a very, very poor family as well, and for some reason, they didn't speak any English at all, and with the limitations with just speaking Spanish, they weren't able to get, speech and occupational therapy and some of the services he should have been getting at home. But even in that setting, at 2 years, I guess he's 2 years and 3 months of age, his mom came to clinic the other day. I saw him for his 2-year visit. He was eating very, very little. She came in the other day just to report to me that he's eating everything, and she's stopped using the formula at all, and she wanted to just be sure that that was okay to do. And so just trying not to pressurize the child, just to allow it to come in its own time, proved to be very, very successful for that child. And I think the children who are going to have the most trouble with eating are the ones who really can't swallow and have swallowing dysfunctions and other reasons why they're not able to eat. The kids who just won't eat because they were intubated for a long time and had tubes and hands and suction catheters and other things in their mouths that shouldn't be going into a baby's mouth, those kids really do learn to eat, and they learn to eat really in like I said, a 2 to 3 year period of time, even without paying, $150 a week to go to specialists who can teach them how to eat. The other big challenge we see is really with the gross motor development. So cognitively, in terms of our kids understanding, when we talk to them, they seem to really hear and understand things fairly well, and seem to have a big challenge with walking. And so the one delay in development we've seen a lot with our CDH graduates is delays with walking. With most of them, the severe ones walking kind of closer to 18 months than to a year, like you would expect them to do. Even then, once they do start walking, they often do have a lot of weakness in their legs, tend to be clumsy and fall down a lot when other kids might be able to recover after they trip or stumble. And I was really excited to see, because just in the last month, in one of the other centers around the country published the first kind of paper that really doesn't speak glimly about the outcome for CDH babies, and really pointed to the fact that, at least in their experience as well, they were seeing something similar to what we've been seeing, where walking really has been the biggest challenge for their CDH survivors, and just developing enough strength in the lower extremities to do that, which was nice, because it really reinforced what I've begun to feel a lot about these kids, is that most of them cognitively do fine, from a fine motor and use of their hands and tools thing, they do okay. The eating, while it's a challenge for the first 2 years, after that generally resolves itself. But the walking and the development of normal strength in the legs really seems to be one of the biggest challenges, at least kind of the new generation of CDH survivors are facing. It seems like we've done a lot to dramatically improve the neurologic outcomes of these kids. The worst thing we're seeing is kids who are walking at 18, 20 months and are clumsy and have some weakness in their legs, but are wheelchair bound and are able to function fairly normally. That gives me really a lot of hope for the future in terms of the developmental outcomes of these kiddos. So like I said, major disabilities are much less of an issue, in the new generation of CDH graduates. I think the next big challenge, which I'm going to see in my practice, is what happens to these kids when they go to school and when it's time to go to school. So we know from graduates from the NICU who are premature babies that attention deficit disorder, learning disability, and then these sensory integration problems are very, very common. So will those minor disabilities be, the predominant thing we see now with CDH survivors? And I don't know. Like I said, the oldest kid in my clinic is 5, so hasn't started school proper yet. We'll have to see if this becomes the major disability that these kids are going to have to deal with now. And so I think getting all these kids screened with school readiness type programs is key before they do start school, because I feel like it might follow a very similar trend to what we've seen with premature babies, where the neurologic outcomes have also improved quite significantly, but these minor disabilities or trouble with school has become the major issue that these kids have to deal with as they get older. They're able to go to mainstream schools and be in the same classroom as their colleagues who didn't have prematurity, but often need some extra help, especially with reading and mathematics. And then this attention deficit disorder is something that for these premature babies is a big challenge. That the kid or the teacher's trying to teach the class and he's running around the back of the class disturbing everybody and throwing his books at people. And so I don't know if that's what the future for these kids will hold. I think, like I said, we're seeing definitely a different generation of CDH survivors now, where this major disability seems, for the most part, to be gone. And there still are kids who are going to suffer with major disability after survival from CDH, but it might be that these minor disabilities are what we're going to have to deal with in the the future. So continued evaluation is essential throughout the early years of a child's life. The key message is at the bottom there. The earlier any deficit is picked up, even if it's just a minor deficit, the greater the impact that any therapy will have over that deficit. So if you pick up that there is a learning disability, the earlier you pick that up, the more effective any intervention you put in place will be. So like I said, we're doing surprisingly well, and really very well from what you read in the literature. If you pulled up all the medical published studies on outcomes for CDH babies, like I said, most of the kids are meeting their milestones. Some are developing at their own pace, but are still developing every day. So, every day there'll be some new skill or task that the child learns. Like I said, up until 18 months to 2 years, most still do have some developmental delay, but by 2 years of age, they really seem to have caught up quite nicely with their colleagues who did not have CDH. And like I said, at least in our population of babies that I've been following, there really are none who have severe developmental delay. And like I said, this is just the last 5 years of patients that we've discharged from children. So growth is the next big issue. The growth failure is very, very common early on. And I know some of you in this room will be horrified to find out that obesity becomes a much bigger issue later on. And this is especially with kids who have gastrostomy tubes, but even kids who don't. While the kids are struggling to grow, we tell you to give all those calorie boosters to get the kid to grow, and then when to withdraw and take those calorie boosters away. It is often difficult to know. You never want a child to start growing beautifully and then you take their high calorie foods away and their growth fails. So this is the kind of growth chart that you often see, where you have a child who's way down on the 3rd percentile, and then it just starts to cross lines as they get older and older. And how to intervene is often difficult. So you see this child struggled in the beginning, they made it up to the 50th percentile, which is the black line. Now some would say you should withdraw calories here, but if you did that, you might see that the child just flattens and plateaus in terms of their growth. So when to withdraw high calorie foods or fortification on breast milk or formula is often a very difficult decision to make. And I didn't put up one of the other growth charts of that baby that I was telling you about, from that Spanish-speaking family, but his growth chart, he was exclusively gastrostomy tube fed, like I said. So his growth chart went straight up like that, and then would go straight, and then go straight up, and then would go straight, and then would drop down. And just to regulate how much intake these babies need as they get older is often difficult, and often we do end up making them overweight just because it's difficult to know when to stop giving high calorie food. Hearing loss is another issue, which premature babies deal with a lot, but for CDH babies, they're at high risk as well. So there's two different kinds of hearing loss that we can see. So there's conductive hearing loss, which is essentially when you have fluid inside of your ear. It interferes with the conduction of sound through the ear and to the nerves that then send that message to your brain. And that's something we've actually been seeing a fair amount of in our babies who are in the NICU for prolonged periods of time. Now, I don't know if that's something that you would see out in the community if you were screening everybody. Babies who are in the NICU when they're 6 months or a year of age are getting hearing screens all the time, just because they're always, every time you fail the hearing screen, they just come back and repeat it a couple weeks or months later, because there's really not many interventions you can do when a child's just 2 or 3 months old. So what we've seen with a lot of these kids, even at 6 or 9 months of age, is that they have excessive amounts of fluid inside of their ear that then interferes with their hearing. And so often they do need to have ear tubes placed even at a much earlier age than would be traditionally done, and even without frequent ear infections or other reasons why babies might need ear tubes to be placed. And then there's sensory neural hearing loss, and that's kind of damage to the nerves inside of the ear canal, and then leading to the brain that causes hearing loss. And you see here ECMO and high frequency ventilation are two common causes of that. And then, ototoxic medications, so gentamicin, one of the antibiotics babies are treated with, vancomycin. All of those can cause damage to the ears and trouble with hearing. And so hearing loss is often attributed to the use of those medications. Sepsis, babies need lines all the time to give them their nutrition and medications early on. And if those lines get infected, that will increase the risk for hearing loss. Anytime a baby is deprived of oxygen, and then any kind of elevation in their bilirubin too high in the first few days of life might cause hearing loss as well. So it's essential that these kids be screened often. It's recommended at least to screen them at birth, and then again when they're a few months old, to see that their hearing is normal. And this is just kind of with the simple bedside hearing test. If they fail, it's always important to realize that that test is what we call a screening test. So when they do this hearing test at the bedside, they want to pick up every single child who could possibly have hearing loss, meaning that they're going to find hearing loss in a lot of kids who don't have hearing loss, just because they don't want to miss any child who might have hearing loss. So they have to pick up every single kid, which means that you're obviously going to end up finding hearing loss in a lot of kids who don't have it. And so it's essential that you don't get upset if your child's in the NICU and they fail their hearing test and think that they're not going to be able to hear, because there's really a large number of kids who have completely normal hearing but fail that bedside hearing test inside of the NICU. So they need to be essentially referred for formal audiologic testing with kind of more sophisticated equipment and devices. Our services are essential for some kids who leave the NICU, so ensuring that they receive these services is really important, and that would be physical therapy, occupational therapy, and speech if those are needed. Medical issues are often at the forefront of treating CDH survivors, and then we neglect the developmental therapy and needs very, very often. So you need to, after going home, focus more on development and less on the medical issues to help the child to move forward, and at least home therapy for the most severe kids is key. So my last slide is just going to talk about kind of the future of follow-up at Children's, and so what we've done essentially is with the help of Dr. Crumblehome and now buying from the surgery team, which has been difficult in the past just because they've been so short-staffed here, barely having enough time to do the surgeries they need to do. is we've decided to essentially start a multidisciplinary CDH follow-up clinic. And so rather than the first floor where the special care clinic is, this clinic will be on the third floor. And that's where the old pulmonary hypertension follow-up clinic was. And so that's where we plan to follow CDH patients. This would be a multidisciplinary clinic where, depending on what the child's needs would be, we will have me there, both to provide primary care as well as to provide the perspective of where this child has been in their past, so that the people working in that clinic don't start the book from chapter 20, like we say. But then we're going to have a pulmonologist there, as well as a pulmonary hypertension expert. And so, Dr. Abman is a pulmonologist who has, worked with Dr. Kinsella, one of our other CDH specialists at Children's, on all of those initial nitric oxide studies. And so he'll be in that clinic, to help provide pulmonary and pulmonary hypertension expertise for follow-up. The surgeons will be in that clinic as well, and we'll see, kids who have different surgical issues at that visit. So if you have a gastrostomy tube and there's scar tissue around it or a granuloma that needs to be dealt with, they'll be there to deal with that. If the tube's leaking too much, they'll be able to help with that. If the child's retching or able to vomit after having had an innocent procedure, they'll be available to deal with and help with those surgical issues. For kids who need cardiology follow-up, cardiology will be present in the clinic as well. So a lot of CDH babies, as we know, have not just pulmonary hypertension, but often have congenital heart disease as well. And so having them there is important, just so that it's a one-stop for families to get all the follow-up they need. And physical therapy and occupational therapy will be present as well to continue to do evaluations on these kids after discharge. And ultimately our plan is to have a neurodevelopmental specialist there who can do all the screening that's needed for these kids as they grow older. So if we see a kid and we think they need to get services and they're not getting services, having them evaluated by a neurodevelopmental specialist will help to get those services they need. And as kids get closer to going to school, getting evaluated by a neurodevelopmental specialist will help determine if some of those learning disabilities are there and kind of what special services the child might need as they go to school. So just to summarize in this last slide, like I said, the follow-up with these kids, for me at least, has been very rewarding, but has been much more insightful than I thought it would be. These kids have done much better than I thought, and their outcomes have really been quite rewarding for me, and has made all those nights that you spend kind of struggling at the bedside and staying awake really worthwhile when you see a kid walk into clinic after knowing what their story was and what they've been through. It really means a lot. Feeding therapy and oral feeding, like I said, has been the most significant challenge that we've had to deal with, but it's very easy and has been possible to overcome. And then respiratory issues really seem to resolve quite quickly in the first year of life, and then long-term development is something that we're going to have to keep a close eye on. Like I said, I think we have a really new generation of CDH survivors now, and knowing what their challenges are, I think is going to be a big hurdle as we move forward. I don't think this is the same population that's been described, in the literature for years and years. So anyway, that's it. Wanted to leave some time for questions, but I know you guys probably have a lot of questions.
Where did they get this information about these children that were that severe? Was it just a select few?
I think so.
You think so?
I think the CDH babies provide a huge burden on the healthcare. The country,
because
a lot of them are.
We've had children like her, and more like this. We've seen more. Yes, they struggle with eating. Yes, they struggle with some issues, but overall.
That's why I wanted to go on this journey myself to see, because I think while it's very easy for surgeons to be very aggressive with the care of patients, for pediatricians and neonatologists it's often difficult, and so they can find a reason to be less aggressive with certain diseases and disorders. I think people prefer to take that route. That's why there's a lot of people who could really tell stories of people they know who had babies who have CDHs where the doctors just gave up. And why did they give up? It's because it's not the same mentality that surgeons and some of the other specialists get trained with. People are taught to be more, I don't want to use the word compassionate because I'm certainly a very compassionate person, but they taught to think first, what is this child going through, and is it really worth it, rather than, does this child really have a chance of surviving, and should we continue to do everything we can to get them there? And I know you've told me a lot of stories in the last day or so about what you went through, and different people wanting to give up and others not wanting to give up. I think there's just a different mentality depending on how you were trained. And I think people who live on the give up side of it find reasons why people should give up.
Yeah.
Bad developmental outcomes is often a reason why people feel like you should stop.
We were talking a little bit about scoliosis. Is that to be expected as and why?
Yeah, so that's a really excellent question. I really should have had a slide on that, so thanks for reminding me about that. So scoliosis is to be expected, and I don't think anyone really understands why. So people always blamed it on the cortex patch or the way the diaphragm was repaired or closed, meaning that there was excessive, even if you do a primary closure, there's excessive tension on the diaphragm that then causes chest wall deformities and then causes the spine to develop abnormally. But if you look at Dr. Crumble-Holmes' population of kids who had this transverse abdominis muscle flap where there really isn't any tension at all in the chest wall, the muscle grows, the chest wall grows normally, those babies still have scoliosis, not maybe as severe as some of the others, but scoliosis is still a problem. And so I don't know if it's just part of the spectrum of CDH.
We thought it was just incidental, we just thought it was one more thing.
It's because one lung is smaller and the other one's bigger, and so that forces the spine to develop abnormally.
What's a percentage or how often does it happen?
It's probably 70 to 80%. It's very, very often.
When do you start to notice that? What stage do you start to notice that?
No, it's hard to notice when they're really active and when they still, because it's a difficult exam to do. So even if you try to get x-rays, if the kid's squirming, like I can make myself have a scoliosis x-ray. So it's hard to notice early on because the kids often aren't very cooperative with the exam. As soon as they can be cooperative and stand still and bend forward and touch their toes. It doesn't need any intervention until they're older. But you need them to be able to stay still,
What should
lean
we
forward
look
and
for?
touch their
Like
toes.
what signs do we look for?
Just the spine should go straight down the middle line between the two big muscles.
But just any curvature, even a little. I know our occupational therapist, maybe once a month when she comes, she does the session with Alicia's closed off so that she can see, like if she's, having issues stabilizing and that kind of thing. She, that's more just for like muscle development and strength and stuff. But she did say that she keeps an eye on just like this, because I had mentioned scoliosis to her in the past, but it's nice to know that she's like looking
Right, that's
at stuff.
another thing as well. So it might be part of what we've seen in the weakness in the legs, is that it might be more than just weakness in the legs, and they actually have weakness in the trunk. And so weakness of the back muscles that are supposed to stabilize the trunk, and then causes the spine to grow.
We have a few kids that are in braces to prevent the surgery, and we have had some kids that have gone through surgeries. Of course, they wouldn't do that until they're home. And I've been a few kids that have had surgeries. Right now, I have like 3 or 4 kids that I know off the top of my head that are in braces and arguing with their parents. Not too rare.
Yes. So do you think maybe like a childlike yoga, starting very early with some of those poses, could help build endurance and help the little ones?
I think so, yeah, for sure. And I think the problem that we run into, which I've learned a lot of lessons about in the last couple months, and this is really the last couple months and not the last couple of years, is that you think because a child walks at the right stage or talks at the right stage or does whatever, that everything's fine. Children are amazing in terms of their ability to overcome handicaps that they may have. So they'll walk because they want to walk and get around, and that's the most efficient way to do it. That they might have a lot of weakness that's there that you just really can't pick up. So anything that you can do, I think, to build any NICU graduate's muscle strength is really important. And so often the kids get discharged from therapy because they're meeting all their milestones. But just because you're meeting your milestones doesn't mean that you have normal strength. And that's at least probably the biggest lesson I've learned in the last few months, is that we have to continue to fight for children to continue to get these services even when it looks like everything's fine and they've dodged whatever bullets you were worried about before.
So parents, when they are, our therapist has released them, so we've met all of milestones, yay, really they should probably have the services continue to,
They really should, but it's hard, because
Yeah.
most of the private insurances, like you have 16 visits a year or whatever, and then to get government assistance is often really, really difficult. So I think it's hard because they get discharged just because these kids are way worse off than them and other places that the therapists need to go and be, that they probably shouldn't be discharged instead.
Have you heard much or looked into early intervention at all, or through the state? Because we ended up, when we got discharged from here, we ended up getting the worst therapy group in Colorado Springs, like set up with them. So I had a customer that was a speech therapist, and she directed me to the early intervention. And it's great because it's like federally and state funded, so anything your insurance doesn't cover, if they pick up, you don't have to pay any co-pays. And they have like an initial evaluation with like 7 different kinds of therapists, like speech and physical therapy, OT, and like a cognitive therapist, and like all these different things. And they're all there watching your kid and asking questions and stuff, so they can set you up with what you need. And that's been really helpful for us. And I think that continues until they're 3 years old, and then if they still have special needs, they can get into preschool for free. I think this whole service is
Goes into the school.
yeah, it's like done
So
by
anything your
school
insurance
districts.
doesn't cover, they said, anything after that, they bill your insurance and they deny it, they cover anything after that. So if you're out of visits, through your insurance, then they'll cover it. So that might be something for these CDH kids here in Colorado.
No, for sure. And it's just interesting though that they were so willing to work with you, because with the premature babies, they really are. What we've seen with a lot of our babies is they do their evaluation and say they don't qualify because they're too good.
Oh, yeah, and that might be, I mean, I could see that if a kid was kind of on track. I mean, we see it,
Well,
I think
yeah.
kids be like 20 or 25% behind.
Yeah.
It's in at least one area to be able to get that
Well, and our
therapy.
therapist now is really good about writing the reports. So like Abel he walked in 14 months, so he was on track, but developmentally his muscles are just not strong, so he's falling a lot. And she was very concerned about that, the balance issues, the muscle strength. So the way that she writes her reports reflect that, so that he can continue to get services. She sees that beyond just the walking and they're done. So she has been very kind in taking extra attention to writing her report. So that's a resource for Colorado. And Maggie let me know about, because it's pretty.
And that's actually nationwide, early intervention.
yeah, there is nationwide, because Virginia, when a child is released from the hospital with CDH or premature or anything else, they automatically send families, our vital statistics, send families information with all the programs they can qualify for, all the contact information, everything else. And after 3, then you go to your school system, because you could enroll into.
And ours is actually done,
Yeah.
Abel's will be done by Cherry Creek, because that feeds right into our school, so they'll do it and have them just follow him from now into school, which
Yeah,
is
the early
great.
intervention here works that way. It's done by school district. So whatever school district you live in, those are the therapists that work with your child, and then they qualify for preschool.
And then there's later on in school, something called IEPs.
And that's what they'll do, is that.
It's actually in Cherry Creek, it's going in. They used to be tied with Children's, where there was this group he's talking about, post-care. They were all these specialists, and your child spent, I want to say, an hour, 2 hours observing them. Then they would write this IEP recommendation to Cherry Creek School, who would then, this follows them through graduation, unless they left the district or whatever. And there's also private foundations, I like the Shriners, or, there's several out there that if you just have exhausted all your avenues and all your numbers and your child is still not up to par, they pay 100%. And you just have to give their diagnosis, and if it falls within their guidelines, which 99.9% of them do, they'll pay. At least here in Colorado, I don't know about anywhere else. Because we used one of those services many 21 years ago, that is still in existence today. That's founded by soft monies, private.
I had a question
didn't have primary care physician like you. I pretty much manage all of my son's separate specialists myself. And then I have a primary care doctor who's just kind of like specializes in asthma, basically. What kind of advice would you give me or a parent who's trying to manage all that without your back? I mean,
Hey, doctor!
Well, you have a lot of families that are in areas that don't have specialized follow-up care, unfortunately.
And they tell me his all of his development is fine, he's all perfect, whatever, but he's definitely got some sensory issues. We were talking about him yesterday with lettuce. Why do we have to keep talking about lettuce? Or like, you know, I mean, it became very apparent for my son at least. We were at a gymnastics birthday party, and they were going through all the tumbling, everything like that, and he was the only child crying at every single event. Now if I go into a doctor, they'll say, oh, he's fine, he's meeting all those milestones, everything, but obviously there's something wrong. You know, he doesn't feel comfortable and he doesn't have the muscle strength to do that. So just kind of curious. I mean, obviously that's not something you can advise on, but I'm just curious what advice you give parents who don't have someone like you to.
And I think you have to find a leader from the physician team to take on your child's case, and that doesn't have to be the pediatrician, you know, and that could be the pulmonary. It's going to be some specialist who has an interest in CDH or chronic lung disease or pulmonary hypertension or something that's going to be intrigued, interested, and passionate about your child's case.
I think right now it's my nurse practitioner at my pulmonology clinic, so she's always worried about his GI and everything. She's the one I kind
And
of.
so that's what you really need, because at the end of the day, everybody's trained to do general pediatrics, even if you're a pulmonologist or a cardiologist. So they can pick up on a lot of these other issues that pediatricians might not, because they didn't receive that same training. And so I think the only advice I could give is that you have to find somebody who's really passionate about whatever issues your child is struggling with. And if they do see a pulmonologist, they could be the pulmonologist, and they're going to need to speak badly about the GI specialist, but it could even be the GI specialist if that's what you're dealing there. Even though neonatologists are the ones who take care of insurgents, the CDH babies after birth, there's a whole team of people who take care of them when they go home who do have a lot of expertise and who are quite passionate about that population. So I think you got to find a leader to take the case on and examine and deal with all the issues, not just the lung or the heart or whatever. And sometimes it's very hard to do the other thing, which we do a lot here, is we do have families come down from wherever they are once, twice a year, just to check in and see the team of people and write letters and talk to their doctors back home and try and help fight the fight for you. And that's often something that I know there's often some expense associated with that, but most of these families are driving from wherever they are, and a lot of them, from North Dakota and places that are quite far away. I have to say we're going to have our vacation in Denver and spend, one afternoon in Children's, or spend some of them, some of our North Dakota families go to Minnesota, and it's just, there's people who just say, this is important, I need to have my child seen by people who really know what they're doing and just feel that I'm just going to take a trip to whichever place is best for them to be, have them seen once there, and then let that team find the pediatrician to get what the child needs. So that's another option as well. So, I think probably 10 or 15% of the kids I see in my clinic I see once a year or even twice a year, and that's all I see them. And the pediatrician continues to follow them, and families are still able to contact our clinic when the child's having problems, because we've seen them already and we know when they are, so we can pull the chart and try and help, even if it's just 3 or 6 months since you were there at that clinic. So that is another option as well.
And my pediatrician's like, I'll see you next year, and I call probably my pulmonologist once every 2 to 3 months. So.
Can you touch on, I didn't know this until you told me, pulmonary hypertension returning.
I thought once it was gone, it was gone. So some of us may need to be educated on it, how it can come back. Because I was under the impression once we are done with it, we're done with it. I didn't know, and I'm sure some
We've
other
had
people.
a few come back. One was through the trauma grounding. And a few others, it was through surgeries that had issues, that sort of thing. But it wasn't anything like, Abel's running around today and tomorrow he's running around and he suddenly has pulmonary hypertension.
No, but with the getting sick and issues that Abel has had, it's very possible. So if you could touch on that. Pulmonary hypertension,
Yeah,
bit.
it's tough because, I think, Maggie was asking me how things have gone since Dr. Crumbleholm came, and we have some differences in opinion, and, what I was saying to her is that he's a world-renowned, world-famous CDH specialist, and here in Denver, we're world-renowned for our expertise in pulmonary hypertension, So he feels a lot that after the first year or 2 years of life, the lung of a CDH patient is going to be identical to the lung of a patient who didn't have CDH, and that differs a lot from our opinion because we've actually done cardiac catheterization on these kids when they're 14 or 15 years old and look at the blood vessels inside of the lung, and it's still, very, very abnormal compared to what a normal. I remember I showed you those pictures of the rat lung that
A
had.
thick one? Is it still thick?
The thickness kind of goes away, but the number of blood vessels is still markedly reduced. And so if you remember those pictures I had of the kind of healthy rat and the rat who we injured the lung, and the blood vessels were kind of all gone away, and then we gave a drug and they all came back. What we see when we do these angiograms when these kids are older is that they still have markedly reduced numbers of these blood vessels inside of the lung, and the lung is still very underdeveloped, even late, and this is 14, 15, 16 years of age, so it kind of actually surprises me that your lung function is normal, and that's amazing, and I'm really excited.
Thank you.
by that.
Excited for your lung function.
In your left lung.
He's gonna ask you to go to the hospital so he can.
I
Do us tell you.
Totally.
Look at your lungs.
By tomorrow.
But, so our belief here really is that this is not a problem that goes away and even into adulthood. These kids are not going to be running marathons, and they're not going to be swimming in the Olympics, and they're going to get short of breath when they try and do stuff that other people can do. And so the risk for pulmonary hypertension really originates from that, in that the vascular bed is still not normal, even though as they get older it responds more normally to different stimuli. So when they poop or get mad or something, they don't try and die every single time that happens, and that reactivity, for lack of a better word, goes away. And the vascular bed is still very undeveloped and not normally formed, and I think that's where that risk comes from. So any stimuli that you or I could handle quite well, they might not handle well at all from that standpoint. And what we worry about is that reactivity that caused them to die every time they needed to poop or had their diaper changed or got mad while they're in the NICU can come back. The most potent stimulus for that to come back, and that what I'm talking about is just the vessels kind of getting mad and just clamping down and closing off, is low oxygen levels. And so anything that causes the oxygen levels that the child is used to go down can cause that pulmonary hypertension to come back. And so the big tonsils that then obstruct the airway and cause desaturations at night can cause those vessels to clamp down. Anytime they get sick, the oxygen levels drop. That can happen as well, but it's different in that whatever the primary process is that's causing it, if you reverse that process, it goes away again. It's not these nightmare stories of the 3-month-old CDH who didn't respond to any treatments or therapies that you gave to them. And we've had 2 families who, the baby's still at 4 years of age, had severe pulmonary hypertension, and we never ever recommend this, but to those two families, we told them they have to leave Denver and go to sea level, and when they went to sea level, the pulmonary hypertension got much, much better, So, like, this is kind of on the spectrum of the latissimus dorsi flap for the infection patch, like the pulmonary hypertension, if it went away before, it goes away again. You just need to find out what caused it to come back and make that problem go away. So while we see, the kids go and have their tonsils out, and then you get an echo a month later when they've had their tonsils out and pulmonary hypertension. Or if it comes back, you do the sleep study, that you and I have spoken about. You see what's happening with the sleep study. You change their oxygen if they're getting at night, or do something different, and it goes away again. It's not that same stubborn, resistant pulmonary hypertension that you see after birth. It's very, very treatable. And the worst case scenario is that you have to leave altitude and go to sea level, and that usually takes care of it as well. But that's when you've exhausted kind of every option for trying to treat it. So I don't want you to be scared that it can come back and be bad like it was in the NICU, because it's not bad like that.
I just thought it was one thing we could check off our list that we were done with forever on, but clearly not. No checklist in CDH.
It doesn't,
you could just grow.
it doesn't go from being gone to being severe. It goes from being gone to being mild, and if you don't do anything about it, then it can go from mild to being moderate. And you still don't do anything about it. Years later, it might be severe, but it doesn't. Just like you're running around and playing, and then the next minute you pass out and you're calling 911, and then you have severe pulmonary hypertension. It doesn't work like that. It's just.
So where does
like
asthma fall in that, I guess?
Any child who needs to be ventilated after birth has an increased risk for asthma. But when you really look at the biggest predictor for asthma, it's really a genetic disease. And it runs in the. So if you have asthma in your family, your child is likely to get asthmatic. If your child had a CDH and you have asthma in the family, you can almost be guaranteed they're going to get asthma. If there's no asthma in the family, the chance is very, very low they're going to get asthma. They might have wheezing for the first few years of their life every time they get a cold, but as they get bigger and their airways get bigger, they'll outgrow that. Like most kids, even healthy kids do, like my son. Wheezed until he was 3, and now he doesn't have any problems anymore. So that's the kind of thing that you'll see with a CDH baby when there's no kind of family history of asthma, or something in the environment that's kind of triggering it to be there. So I think the risk is low unless there's a very strong family history.
I have a question. When are they graduated? When do you say, okay, I love you,
Never.
but for example, here, if Miss Katie was your patient, obviously you would like to keep in contact with her. I know it becomes, not as frequent, but, and now there's genetic studies that maybe weren't available when she was a child or an infant or adolescent for that
There's also
matter.
issues with adults not being able to find doctors that will treat them that know about CDH.
So my hope is really not for anyone to graduate, but at some point in time you have to cut loose from the primary care part of it and just be the CDH specialist, And so when they're healthy and a lot of these things that we've spoken about, check off the list, and you're not really worrying about them a whole lot, then just following up once a year or every 6 months becomes fine, and going to see just the regular pediatrician for other issues. And so there are some kids who have done that before, where they have gone back to their regular pediatrician. They just come see me once a year, and they just make sure everything is okay, and then they go back. And if the family gets frustrated with the pediatrician in the intervening period, you can always come back. It's just,
Okay.
For you guys, it's not too bad. For some families, they drive 45 minutes to get here when they can just an hour and a half. When they can go see somebody who's 5 minutes or 10 minutes away. It's kind of silly. At some point, it becomes silly to make that drive. Not really doing anything different from somebody else.
Now I know there's a lot of, with CDH babies, obviously there's a lot of feeding issues and stuff too. And this is a little off course, but Adrian also had duodenal atresia. Is there also a lot of complications with that for feeding and digestion and whatnot as well to go along with it?
No, and the digestion feeding issues will be related to the CDH, once that's taken care of. Because he had it for so long, getting his feeds initiated was a big challenge, but now that he's doing well with these feeds, it shouldn't be a problem. Just getting him to full feeds, which we know was a big challenge, was his challenge that he had to face, but now that he is tolerating full feeds, the tuition and treatment should be
Okay.
I guess, is there anything else our baby shouldn't be doing? They let her do everything. And Wayne said no football, so is there anything that we should be cautious about, or are they good? That patch isn't going anywhere. Like, you're not going to get tackled.
Probably no UFC everything.
Oh, none of that. His brothers do that with him now.
My recommendation is no trampolines.
Oh, we have a trampoline
Oh, we have
and they
a
love it.
trampoline. He jumped on it now. That's what I'm saying.
Pediatric surgeons will tell you why.
So is there anything, I guess that's our question, is there anything I should say no? No football, no this or that or the other that you see that could be potentially dangerous, other than he's a boy and dangerous?
And he has 4 brothers that are gonna make him do it anyway.
Yeah, I mean, Abel's case is a little bit different because he had to have a heart surgery as well. So I think in general for CDH patients, I'd say what we would recommend for all healthy babies, we would recommend the same thing for them. She says trampolines because trampolines are a health risk for kids. Not your trampoline because you have the safety.
If you can jump on it, it's safe.
Well, I mean,
But-
I just know
but it's-
generally, you're probably more
The
aware.
trampoline.
Yes.
The trampoline warning is the same as the riding a bike without a helmet.
Yeah.
Yeah.
Like there's ways to ride a bike safely and there's ways to go safely with trampolines, but in Abel's case is a little bit different because of the heart surgery. I'd have to see when he gets older with the heart surgery and so on. So getting big battles against his chest.
So we won't ever stop seeing you, basically. We don't ever get to check
When
that out.
he's
We
ready-
go to the regular
Yeah,
doctor.
she's never gonna let go.
When
He
he's
might
ready-
let
when he's ready
go.
for football, let me know.
Is there? We'll talk about it when he's in high school and ready for football.
I just have recently seen on Facebook a couple times about people commenting on their child had ECMO and then doctors told them like not to let those kids play football or something with impacts, or I mean, is there any kind of long-term things that we need to know about, like when you say having had ECMO?
Yeah, ECMO is hard because we really don't know the long-term effects of having that vessel tied off. So ECMO has been around for a long time, but not for 70 or 80 years when people start getting, fat plaques and stuff inside of there. So the risk with ECMO is, I'm sure you've heard of already people who get narrowing in their carotid. So you just don't know with patients who've been on ECMO if those narrowing in those plaques, if they lose their left side from one of those, if they'll actually have a stroke or the back circulation in the brain. So the way the brain works is there's 2 vessels in the front and 2 in the back, and then they all meet in a circle, and the blood flows around that circle and then distributes to the brain. So you really, theoretically, should be able to take both of the carotids out, and the brain should still get perfused from the vessels in the back. So everybody is hypothesizing that it's probably fine to lose the carotid or even both carotids, and you should still get the blood flow to your brain, but nobody knows really when you're 75 and 80 and you get those plaques inside of the vessels, whether the risk for stroke will be higher
If
or
you
not.
live that long too.
Because we feed them nothing but butter, I'm
That's
pretty sure that
right.
they're gonna be in high risk category here.
That's really the only kind of concern that people worry about. But what's really interesting though is that if we've sent some kids for ultrasounds of their neck 2 or 3 months after ECMO, and we've often got called by the radiologist asking if the child had VA ECMO or VB ECMO where they had the catheter just in the vein but not in the artery because the ultrasound flow pattern in the carotid was normal. Not normal because the carotid was normal, but what's amazing about kids and young people is the ability to grow new blood vessels is the same way they grow new blood vessels in their lung. When you tie off the carotid, they grow new blood vessels around it that then perfuse the brain. Or anytime they have a material line, it's the same thing, like new arteries form around where that catheter was to perfuse the hand out of the signs. So they've often called us and said, "You sure that child had VA ECMO because the flow pattern from just the collateral blood vessels is completely normal." So I think the body has kind of a remarkable way of taking care of these issues. If you look at animal studies that people do, if you tie off the main blood vessel to the leg, the animal won't walk for 2 days, and 2 days later they'll be walking and the leg will be working fine. And it's just how the body deals with getting rid of major blood vessels that should be there, is it just grows new ones. And so I don't think there's going to be any problem related to it, but nobody really knows the answer. I think they hold us that most survivors are in their 30s now. It's still too early to tell.
Any other questions?
I was just going to tell you the baby that our pediatrician called me to come and talk to the mom after she had a diaphragmatic hernia baby. He now rides bulls. Is that terrible?
Jason's
The difference
crazy.
in age, you know, he had ECMO. There was no ECMO when Katie was born. But when she said that they allow him to do that, it was like, I mean, he's a man now. But
I can't tell my grown son, "Hey son, I don't really think at age 35 you should be doing
Riding a
this
bull.
thing." So I
I'll
guess.
tell him you can't ride a bull.
The wiggle race, you do it all. You follow the horse.
Yeah.
Those country folks, you get back
Worse than I
and
am.
you don't, you never tell them no. Within, yes.
How much does the
if she wanted to ride sheep or anything, no.
If she wanted to be a mutton buster.
Or with her strong will, she might. Behind our back.
She's like, I've already done that. You just said no.
Yeah.
No way, no. I have my own parameters as well.
There you go.
That far either.
And Dr. Cumberland couldn't believe how many kids go home on oxygen here. She said in Cincinnati hardly any.
Is it just because of her?
Altitude.
Your altitude.
It's funny, my pulmonologist goes to the ICU, when we were there, he went to the ICU pulmonologist and he said, off oxygen, off oxygen, off oxygen, off. He would just take like 15 kids like off of oxygen, and they would all be fine, they were all just on it because the previous attending pulmonologist before was like really cautious, and he was like, no, off. And then we had like all the kids off oxygen. It's really weird.
Nine the sea level altitude difference is huge. When you think it wouldn't make a big difference, but I mean, if we have even 15% of like brand new healthy non-CDH term babies going home with oxygen, even just from the altitude. Like they don't have any problems at all. They just don't like being in there.
Any other questions?
Yeah, will it worsen if you go higher in altitude?
Like,
Where are you moving?
What to the
To the top of Pikes Peak? I don't know. Should I regulate it to like if I'm gonna go on a family trip and we're gonna drive to the top of the mountain with the family?
Leave him turn at the bottom of the hill.
Should I leave them down? Yeah.
I'll tell
Like,
you.
sorry son,
I'll tell
she
you.
can't go
No.
because.
I'll tell you
that's
the
actually
answer.
really good.
We went to Black Hawk while Abel was on oxygen, and we were advised to crank it up because we were going up to the mountains, so yes,
How much would
probably.
you say to increase it, because like,
to double it.
double it really?
Okay, so I'm
Well,
thinking of going up Mount
fly
Evans this weekend with my son. Should I be considered? He breathes fine, he's always had really high oxygen. 900 all the time, so he's probably fine.
Yeah. Hopefully.
So you need to get down
I mean,
to
I would-
an eighth
I'm
of a liter so you can go back to Gunnison.
I don't
So
know.
Gunnison at 8,000, should I be planning to move to Alaska? 50 foot below?
No, you just need to give a appropriate amount of audience. But I would honestly just watch closely to see.
I
You
can
have to go over 12,000 feet and then you have to smoke.
Yeah, we'll give you enough oxygen, don't worry.
Well, we also, there's
No, but I mean,
Mom might need some too.
If you are gonna go up Mount Evans, I just keep it, like just look in your rearview mirror and just make sure.
Make sure your zips aren't turning green, it's not
turning
blue.
We also recommend oxygen before you take your CDH child anywhere on a trip by plane to go to your doctor to have them checked out, or if they have oxygen, they need to be written things. So
Yeah, before you can
airlines
board an aircraft, every carrier requires not only a physician's note, but the oxygen container has to be FAA approved.
Yeah.
And we have problems with this all the time. They bought $5,000 worth of tickets and baby and the child on oxygen can't get on because they don't have the physician's paperwork, or it's not an approved FAA to fly. So it's more common than you would think. And it's
No, it really is. I mean, those questions you guys asked are really good questions. 'Cause, I mean, I used to work in the pulmonary hypertension clinic as well, and we had 2 patients. The only reason they were diagnosed with pulmonary hypertension is because they went to Breckenridge, and when they went to Breckenridge, they couldn't breathe and got really short of breath. And, you know, they called 911 and got given oxygen, and they did fine, and then were told just to go back to Denver. And then their pediatrician was like, "No, you should see a pulmonologist."
Oh my goodness.
You know, and they did fine on oxygen, but as soon as you took the oxygen away, they had pulmonary hypertension. So I just keep an eye on it. I mean, I think it'll be
Should
fine.
plug in his
Just-
neb and just have the air breathe in his face.
just keep an eye on it. Yeah, and you know, for you guys, he'll do fine. You know, it's just you're gonna have to give him more oxygen. That's all it means. So what oxygen does is it just makes up the difference between the atmospheric pressure at sea level versus here. So you might be on 1/8 of a liter when you leave here, and you might have to be on 1/4 or 1/2 a liter when you get home, and that's the difference that it will.
Or you guys could just move here.
Huh?
You could just move here.
No. I'll move to Sacramento.